All right, thank you all for gathering this morning for our grand round. It is my pleasure to introduce two speakers for us this morning. One of them, one of our crack residents in neurosurgery, Kushal Shah. Kushal graduated from UMKC in 2010. Did an internship in Chicago at Advocate Lutheran Hospital and has been one of our outstanding residents here, is now a PGY4. He has a number of publications in preparation, one actually in publication as well as a book chapter, and a number of other research projects he's working on, some of which you'll hear over the next remaining couple of years of his residency, should he finish. No, of course. And the second speaker this morning, sort of dueling hemicraniectomy speakers, will be Dr. Abhijit Lele. Dr. Lele was a 1994 graduate of the BJ Medical College in Pune, India, where he achieved his MBBS, completed a residency in pediatrics. She never told us. We would have kept all of the PICU patients up in the neuro ICU if we'd known that. In 1998, at the same facility. He completed his anesthesia residency at St. Barnabas Hospital, New York City, a Mount Sinai affiliated hospital in 2004, and a critical care fellowship, a neurocritical care fellowship at the Johns Hopkins Medical School in 2005. And just this year, he's completed his master's in clinical research here at KU Medical Center. Dr. Lele has won Faculty of the Year in anesthesia a number of times, has a number of publications and book chapters as well, and we will be missing him greatly this next year as he moves on to greener pastures as Director of the Neurocritical Care Unit at the University of Washington Medical Center in Seattle. So we wish Dr. Lele best in his new position. We're going to be crying for a long time this year when he leaves. But with that, I introduce Dr. Lele and Shah, speaking about hemicraniectomy for large hemispheric cerebral infarction.
So I think the way we designed this is to kind of track theme, and so I think we'll do a few slides. I'll go through as we move along. But before we start, thank you, Dr. Camarada, for a nice introduction, and thank you all for coming here. Like Dr. Camarada said, this is really my last presentation to this audience, so mixed feelings as I leave, but we're in good hands here. So.
Well, good morning, everyone. Hope you can hear me well. So this has been a task force that we've kind of undertaken now for nearly a year, specifically to look at hemicraniectomy for large hemispheric infarction, something I've been interested in, as well as Dr. Lele and Dr. Wong and Dr. Ebersol. So it's something that we've been working on for quite some time, and wanted to share that with you today and show you kind of where we started and where we've come now. So we're going to start with some basic case scenarios and just review and see, what should be done, what did we do, and what would you do, and then we'll review it later and see if that was the right decision or not with the data. Then we're going to do a quick pro-con debate with Dr. Lele. Showing the pro for doing the surgery and decompressing the skull in these large hemispheric strokes, and then I'll be presenting the con debate. We'll be reviewing the clinical data that's been published in recent years that will help us determine what's the appropriate treatment, go over the NCS and stroke guidelines for these cases, and then review some controversies that still exist in some areas that hopefully will improve over the next few years with further studies coming out. And lastly, we'll show you how we constructed our KU decompressive hemicraniectomy clinical pathway, as well as what it is to review so that we're all on the same page. So I'd like to just start with a few case scenarios, and this is interactive. So first patient here is a 72-year-old gentleman with a, as you can see here, right-sided stroke. Came in about 36 hours after his symptoms. He's found to have a large right ICA occlusion. He's got atrial fibrillation, and his GCS was 8 at that time. His 4 score was 9, and his NIH stroke scale was 14. So just want a raise of hands. Who in the audience here would offer this patient a decompressive hemicraniectomy? Say that again. Yeah, so he's about 36 hours out. And this is his MRI showing pretty large. So who would offer this patient craniectomy? Who would not offer this person craniectomy? And who doesn't care?
Is he getting worse? Or is he staying the same?
Wait. So
What's he doing clinically?
So clinically, he's a little bit somnolent. But he will follow commands on his right side. On his left side, he's completely hemiplegic. And
What is the baseline function? Is this guy like a 52 or this guy like a 92? So his MRI looks pretty good there. Didn't have much atrophy. I think we cannot just use the age as the deciding factor.
So his baseline function was pretty good. He was independent at home. He's retired, lives with his wife.
Climb how many stairs he can climb?
So we're not going to belabor these points now. These are some of the most controversial points that we are going to discuss later in this presentation. So keep those thoughts.
He does not have massive like scan. There's no midline shift. There's no transdental radiation. So you would argue, you would observe him closely and decide at the earliest sign that now he's appropriate candidate after you've done the intermediate measure, hyperventilation, medical. But I mean, I'm not sure many people will be compressing at that stage.
So and there's and we'll show some of the literature a little bit later versus early versus late. When's the appropriate time, and who should and shouldn't get decompressed. So this next patient's a 70-year-old gentleman, also had a right-sided stroke. His symptom onset's been about 96 hours. He's got hypertension, diabetes, and atrial fibrillation. And he presents to us. He's intubated. He is hemiplegic on his left side. He will localize. He's on his on his right side, but does not follow commands. So same questions. Who would offer this patient a hemicraniectomy?
You don't show the lower shots. Because here there's midline shift. So, yeah.
Correct. And who would not offer this patient hemicraniectomy? And who's uncertain or doesn't know? Is it because he's 70?
Send him to KU.
Not a pediatric patient. So, and this is our last case scenario. It's a 57-year-old gentleman who presents, who's actually 7 days after his initial presentation with a left-sided stroke, dominant side stroke. And he did initially get IV TPA. He was stable, in our neuro ICU for quite some time, and then on day 7 blew his pupil, became extremely lethargic, and this is the scan you have here. So who would offer this person? And who would not offer this person? And anyone who's uncertain. So, all right. I'm going to have Dr. Lele come up, and we will remember these cases because we're going to review them at the end, and we'll tell you what happened.
So just like Kush said, I think these case scenarios are real life. This is the cases that we took care of at KU. So I think it's good discussion points for Dr. Wang and other people brought out. So let's go over a little bit of the introduction. So large hemispherical infarct, or people may call it as middle cerebral artery MCA syndrome, or MMI, middle cerebral artery malignant MCA infarct, follows a typical clinical course ending in herniation. The epidemiological data suggests that about 10% of all large MCA strokes will present with kind of large hemispherical infarcts. And the underlying vascular lesion is usually very proximal, and there's always a risk for MCA as well as ACA territorial affection when you have a large MCA infarct. The mortality with medical management is about 80%. So despite best aggressive medical care, and coma terminates in brain death within about 2 to 5 days of onset, and if the patients survive, they usually are severely disabled. So this is kind of the baseline data that we have for a large MCA stroke. So just going over history of MMI, and just put some trial data in there. That
Is this data pre or post TPA?
this is pre-TPA. This is all pre-TPA data. So again, with the MMI syndrome or malignant MCA syndrome, early kind of brought out in the literature in 1970s, and then had really the Werner Hacke from Germany really coined the term malignant MCA infarct. And then the trial data, there have been about 5 randomized controlled trials thus far, starting with Destiny, Decimal, Hamlet, Head First, and then Destiny 2, looking at various different questions that you guys all raised: age, side, time, and everything else, and really the outcome. and we'll go over those trial data in a little bit. But for the sake of this particular talk, I'm going to restrict my talk to say okay, large hemispherical stroke should be surgically decompressed. So what I'm going to propose is that decompressive hemicraniectomy should be offered to all patients with large hemispherical infarct. Again, this is not how we practice clinically, but just for the sake of argument, we're going to say, okay, we're going to offer it to everybody with a large hemispherical infarct. And I think the rationale behind that would be like, somebody asked the question, how is the patient doing before? I mean, we heard this all the time that patient is fully functional before the stroke happened. The patient and the family, they want everything done. And when their minds everything done may include medical or surgical management. And aggressive medical management, despite in the best of the settings, is usually not enough. And in my mind, when you see a large MCA or an ACA stroke, we are kind of simply waiting for herniation to occur. So when you talk about the timing to take the patient in for surgery and things like that, those are all important, but we're essentially waiting for the inevitable, which is herniation and brain death to ensue. And there's a provider variability bias in how patients and folks approach large hemispherical infarct. And by that I mean that some patients are biased by age, some providers are biased by side, some providers are biased by historical data where maybe they didn't operate on patients with a left hemispherical infarct. Although the recent trial data, as we discussed, does not differentiate between left and right side or dominant versus non-dominant hemispheres. And thus I think we are doing self-fulfilling prophecies of poor outcome. Just like in many other neurocritical care topics, if we don't offer the patient surgical management or best medical care, we are pretty much going by the data that has been there 20, 30 years ago. And if you look at the trial data very closely, the number needed to treat to save one life, you have to do 2 decompressive craniectomies. And to be able to walk without assistance for one person, you have to do 4 decompressive craniectomies. I think that's a very strong number needed to treat from any large clinical trial data. So I think these are the factors that I think make it important that we should offer decompressive craniectomies to all patients with large hemispherical infarcts. Now, whether they decide to choose it or not, that we'll go over that as we construct our clinical pathway. I think we've given a lot of thought to everything besides just what you see on the MRI. And what you see on the age, what you see on the timing and everything else. I think there's a lot more to the story as we'll uncover as we move along with the slides. If you look at the medical management, I'm going to complete my rationale with what can we offer these patients medically. And these are some of the data from Neurocritical Care Society, from American Heart Association, American Stroke Association. And these are some of the guidelines and some propositions they have that decompressive hemicrania is a potential therapy to improve survival regardless of age. Now that's a pretty bold statement to make because we've seen patients who are 60s, 70s, 80s, or 20-year-olds. In patients who are more than 60 years, the patient and the family wishes are very, very important because severe disability is anticipated. There is insufficient data to say that you base your data, your thought process against decompressive crania based on hemispherical dominance. Decompressive crania should be performed within 24 to 48 hours of onset of stroke and prior to herniation symptoms, which is not often, in the best of scenarios, easy to pick up and quick to intervene. The size that is proposed by Neurocritical Care Society is about 12 centimeter minimum, about 14 to 16 centimeter of the craniectomy size. They say the larger the size of the craniectomy, the better the outcomes. And again, you individualize your approach for duroplasty or lobectomy based on individuals. In some trial data also, some patients have got a decompressive crania before, only to come back maybe a few hours or a day later for a temporal lobectomy on that side. And what do we do clinically for these patients? We keep their cerebral perfusion pressures high. So the recommendations are to keep MAPs greater than 85 in patients who don't have a bleed on their CT, either post-TPA or otherwise, and maintain systolic blood pressure less than 220, which we typically do in all of our patients. Intubate for neurological or respiratory deterioration. And then typically these patients would end up with a tracheostomy around a week to 10 days from their onset of stroke. And then analgesia, sedation, lowest possible sedation so you can get a reliable neurological exam. Keep their blood glucose within, I would say, permissive range now. We don't talk about 80 to 110 anymore in the critical care world for maintaining blood glucose levels, so 140 to 180. And then hemoglobin greater than 7 grams, and then thromboembolism based on each institution's protocol. And then for these large hemispherical infarcts, it is not advisable to restart oral anticoagulation at least 2 to 4 weeks after the stroke onset, just because of risk of hemorrhagic transformation. It is advised not to perform prophylactic hyperventilation for these patients because you are going to cause vasoconstriction and cause worsening of neurological injury. If you are dealing with a patient with a large hemispherical infarct who's under sedation, I think this is controversial whether to perform daily awakening trials for these patients because, as you can imagine, these patients get extremely agitated, and even with the respiratory therapy, sometimes their blood pressures can be extremely elevated, and they may cause more trouble than good. And then obviously there's no role for steroids for brain edema, and the overall consensus right now is against barbiturates. Although I think there is some specific role for barbiturates in these patients as we move along with medical management, but I think routine use of barbiturates is not really recommended for these patients. When I mean barbiturates is to induce barbiturate coma or burst suppression on the EEG. And we are restricting the talk to only hemispherical strokes, but I think the data for cerebellar infarcts is even more clearer. I think there's no debate about that's the reason why we didn't include them in our current talk here. But I think so. I have very strong evidence from my own Neurocritical Care Society and from American Heart Association to say that yes, these patients should be offered a decompressive craniectomy if they have a large hemispherical infarct. And I think Kush will talk about, why we should not offer them to all patients and kind of from a surgeon's perspective, if you will. So.
Questions?
At the end.
So to play my side of the debate, which is saying that all patients should not get large hemispheric infarction, just like Dr. Lele mentioned. So some of the issues that we've faced in our personal experience as well as other people's experience is that there's been unrealistic expectations. A lot of times families, they're told they have a horrible stroke and this surgery is going to fix it. But truthfully, we're not curing the stroke or even really treating the stroke. We're only decompressing the brain and preventing herniation. So that is one of the things. And patients don't do well despite surgery. Even though you offer them every single maximum medical thing possible that we have available to us, they still don't do well. One of the concerns that I know a lot of families share is, well, you've saved my loved one's life, but now they're in a vegetative state or in a state that they're going to need care for the rest of their life that may be a big burden to the patient's family and society and other members that help take care of the patient. If the patient has significant medical comorbidities, that certainly increases their surgical risk. And lastly, many patients' families go palliative after having the surgery, and the patient's outcome cannot be measured soon after surgery. We know that we can prevent death, but what about the significant improvement? Waiting a week or 2 weeks or even 3 months is not necessarily enough to truly justify the outcome of that patient. That may not be long enough. So all these points kind of have led us to delve into the data and review the important clinical trials. So modified Rankin score, I'm sure most of you are familiar with this. I'm just going to take a slide to review that because this is a really critical scale that has been used in all the trial data. So the multiple randomized control trials have come out of Europe that started around 2007 and have continued to the present, and they all have defined their outcomes based on modified Rankin score. And patients who have no symptoms at all, who are at their baseline, would be a 0 to 6, would be dead. Now, it's important, you can see here, 2, 3, and 4 have been highlighted. Patients with a modified Rankin score of 2 have a slight disability and are unable to carry out all their previous activity, but are able to look over their own affairs without any assistance. People with a modified Rankin 3 have moderate disability requiring some help, but are able to walk without assistance. And a modified Rankin 4 is moderate to severe disability. They're unable to walk without an assistive device or an assistance of a person, and they're unable to attend to their bodily needs. So depending on where in the world you live and who you read, a lot of people say that 4 and above requires nursing home care or substantial care, versus 3 and under does allow that person to stay in their home. One of the downsides to this scale is it doesn't take into account other things such as language and other factors. So there have been other scales that have been used to supplement this data, but as you'll see here, this has been the kind of the standard for most of these trials. So, like I had suggested, there's been multiple trials: Destiny, Hamlet, Decimal, and Destiny 2. And I'm just going to take a few slides here to review these. Destiny was one of the first in 2007, and they looked at patients who were 18 to 60 years old, and they randomized them, and they had a total of 32. Their NIH stroke scales were 18 or greater for non-dominant and 20 or greater for dominant side strokes. And their criteria required that a CAT scan showed 2/3 of their MCA territory be involved. And these patients were randomized in 12 to 36 hours. And what their primary outcome they were looking for were for mortality, as well as an MRS score of 3 or less or 4 or greater. And that's what you can see here on the table on the right. So mortality, they showed with substantial benefit that 18% who underwent surgery had mortality versus 53% who did not undergo surgery and just underwent medical treatment. And that's statistically significant. And Dr. Lele alluded to that earlier with the number needed to treat of 2. Now, when we look at their primary outcome of an MRS of 2 to 3 versus 4 or greater, there was not a statistically significant difference. Patients in the medical arm had 27% versus people in the surgical arm had a 47% difference. And that was at 6 months, but then if you carried it out further at 1 year, it was not substantially different. And can't have a stroke talk without having one of these tables on there. So you can see here how their functional outcomes compared. On the top left, this is at 6 months, the MRS scores, and B on the bottom on the left is the 12 months, which is a representation of that last table I showed you. And then, as I had mentioned, there are other scales that are used, the Barthel Index in the top right, and the functional outcome based on NIH stroke scale on the bottom right there. So you can take a look to see how they categorized. Another study was the Decimal trial that was also done in Europe, which was a randomized controlled trial. And they randomized 38 patients who were all less than 55 years old. All these patients had an NIH stroke scale greater than 16, and their criteria was based on MRI, having a DWI volume criteria of greater than 145 centimeters cubed. And these patients were randomized in less than 24 hours. So once again, just like the last study, they were able to clearly show that statistically significant, there was a 30-day mortality difference between patients who were only treated with medical treatment versus patients who also were offered surgical treatment and underwent surgical treatment. 78% had a 30-day mortality in the medical arm versus 25%. And in the looking at MRS of 2 to 3 versus greater than 3, they did not show any statistically significant difference, but when they looked at a subgroup analysis of their data for patients that they were able to separate from 4 or less or greater than 4, there was a statistically significant difference. And so the medical patients had only a 22% chance of being in that group versus a 75% chance in the surgical arm. So after all these studies came out, people started asking, well, what about patients who are older? You know, a lot of these studies had 60 or less or 55 or less, and a lot of experts in the country and the world noted that, well, I think these patients should get it, but what about patients who are older? The stroke population a lot of times involves patients who are older. And so Destiny 2 was a randomized controlled trial that was conducted, and these patients had an NIH stroke scale of 14 for non-dominant side strokes and greater than 19 for dominant side strokes. And 2/3 of their MCA territory was included, as well as the basal ganglia. And these patients were randomized to less than 48 hours. And you can see a Kaplan-Meier chart here on the right side that showed how the survival was in these patients. The hemicraniectomy group, just like the other trials, showed statistically significant greater chances of survivability compared to the control group. And here, the chart on the right shows that the MRS score of 3 or less in the medical arm was only 5%, and the surgical arm was 6%. And then how about less than or equal to 4? It was 18% in the medical arm and 38% in the surgical arm, which was statistically significant. The overall mortality rate in these patients was quite quite high in the medical arm, 76% and 43% in the surgical arm, as you can see. And the majority of the patients in the medical arm did die because of cerebral herniation. Now, I think this is important to note that when you look at these numbers compared to some of the other trials, the actual numbers are lower. And I think that is largely dependent on their age, their comorbidities. These are sicker patients that led to the outcomes not being as good. But they did show that at still statistical difference in mortality as well as MRS of less than or equal to 2. Unfortunately, they did not have a subgroup analysis in their paper for the highest age group, 71 to 82. 82 is the oldest patient that was randomized in their trial, which I think would be helpful to us, but unfortunately that data is not yet available. And then one more trial that was done around that time was the Hamlet study, which also looked at patients who are 18 to 60, so the younger age group who had less than 96 hours from stroke onset. Similar inclusion criteria, and they looked to see if early versus late made a difference. And patients who had surgery before 48 hours had decreased mortality and decreased evidence of poorer outcomes, but patients who were randomized to less than 96 hours did not have any significant difference. And the nice thing about this study was that they not only looked at 1 year out, but they looked at 3 years out. So, how are we doing at a year? But more importantly, how are they doing longer term? Are these people showing that they're able to sustain or show any signs of improvement? And what we were able to show is that for the medically treated patients at 1 year and 3 years, the patients who died typically died right away or in the first year. But then at 3 years out, the mortality didn't increase substantially, as you can see here by the black bar in the second and fourth column. And then that was pretty much true for the surgical arm as well. In terms of people who are MRS4 or higher, those numbers stayed about the same. It wasn't substantially different. And same thing with 0 to 3. Now, patients who did have surgery, just like we showed before, had a higher likelihood of being 4 or less. And then the last clinical trial that I'm going to review here is called the Headfirst trial, which is the most recent trial that looked at patients who are 18 to 75, so a broader age group. And they had 26 people randomized in their trial. And surgery was done within 96 hours, and they were randomized within 4 hours of meeting the inclusion criteria. And in their trial data, they included, shift that you had mentioned earlier. And so, interestingly, their 20-day mortality was substantially different, with the medical arm being 40% versus 20% in the surgical arm. But when you looked out further, their 90-day and 180-day mortality was not statistically different. Turn over to Dr. Lele to discuss some of the controversies.
So as we've seen through the trial data, I think the three most important controversies that we wanted to discuss was age. I think there is very clear data that the younger the population, against as in the trial data, the more benefit, at least the trial data has shown. So I think less than 60, I would kind of mark it green. 60 to 70 is kind of the yellow area, if you will. We don't have much data yet on them. Maybe there's some benefit, but we're not quite sure yet. I think we still should offer 70 and 60s again. And greater than 70, really there is no data right now to show that they would benefit from a decompressive craniotomy for short-term, long-term outcomes, especially mortality and morbidity. If you look at the timing, the earlier the better. Less than 24 to 48 hours clearly has shown benefit, and I'll go over these controversies over the next few slides. But greater than 48 hours, again, at least the trial data is not very supportive of that. And then dominance of hemispheres, clearly, I think that's a controversial topic in itself, but we'll look over that as to what is the current data on meta-analysis of all these randomized controlled trials. And then some of the outcome measures. I mean, is MRS a good outcome measure for these trial data, or look for psychosocial, financial, caregiver burden? I think nobody's really looked at those aspects. And as further clinical trials are designed, perhaps that is another opportunity to look at those outcome measures very closely. So Rishi Gupta from Emory and Sandra Connolly from Columbia did a nice meta-analysis of all the trial data. And if you clearly look at the age as one of the controversial points, is the younger the age, obviously clearly has a better chance of functional independence. So, I mean, and we are going to review some of our KU data as well. We have some KU data, preliminary KU data that will go probably in supportive of this. But if you look at so what about age? I think if you look at age, and like Dr. Shah said, greater than 70, again, I think the trial data is not really very good forthcoming. I mean, again, if you look at all 5 randomized controlled trials, probably cumulative data is only 140 patients. So it's very difficult to do subgroup analysis on these patients when you're really not powered for looking at age of greater than 70 years. Again, no good data to support that, yes, we should offer decompressive cleaning for everybody that is above the age of 70. Again, we know time, right? If you look at time, space it out between 0 to 24, 24 to 48, and then moving on. This has been controversial. The question behind this is like, when do you intervene? Do you intervene on a patient who's awake following commands without a blown pupil at 24 hours? Or should you wait for them to have a neurological change and then take them to the operating room? I think that's a question that we've battled many times in our clinical practice. And I don't think we have a good answer to that right now. But just going by the trial data and when they were randomizing these patients, they met criteria, and earlier the better. SIDE, look at the trial data for SIDE. Out of 138 patients, only 27 patients had a left-sided decompressive craniectomy done. Whether it's biased towards offering the patients craniectomy or it's the way the data presented, I don't know. But just you can take your wild guess on this. And so we can see that these age, SIDE, and timing are important, and we have incorporated all of these things into when we consider our clinical pathway as to how to approach them. And then, complications for decompressive crani, I think if you look at them, I mean, it's a surgical procedure with some immediate and delayed complications, including insufficient decompression. So I think the size is very important to consider. Surgical site infections, about 5 to 10%. Hemorrhagic complications. Again, the trial data is, like I said, is excluded patients who got IV TPA. We've performed cranies on patients with post-IV TPA management. And so I think that's a concern from a surgical standpoint. And then contralateral subdural effusion is an immediate complication. And for delayed complication, including sinking flap syndrome or extraction fluid collection or hydrocephalus subdural hematoma. Again, point to note is that despite best aggressive medical care and decompressive craniectomy, the mortality is still about 20%. So let's go back to our 3 patients and see how they performed and who were offered craniectomies and who were not.
So as you recall, these were our 3 cases from the beginning of the presentation. And so this is the first patient who underwent decompressive hemicraniectomy less than 48 hours out.
So I think the audience, only one person?
I raised my hand as well.
Yeah.
Had 2 people had voted.
Yeah. So he did undergo the procedure. He had a pretty lengthy course in the hospital, continued to have a lot of issues, underwent induced hypothermia, barbiturate coma, underwent trach and PEG, was in the hospital for a total of 15 days. He eventually, when he left the hospital, was an MRS-5, and the family, after all this, elected for hospice about 2 months afterwards.
How far out is he now?
So unfortunately, we don't have any later data. Just the last data in the chart that was available was that they had elected for hospice, and he had went to a hospice.
Knowing what you know now, would you have offered him decompressive craniectomy?
I personally probably wouldn't have, but I think that's an individual decision, and we're going to kind of go through the clinical pathway of how to make that decision.
Does he have his cranial flap back on, or does he have a big hole in his head?
Yeah, he never came back for that, so I think the family maybe elected to let
Is
nature.
this what he looks like with this huge bulge?
This was post-op, immediately post-op, so I'm not sure if it's sunken
The
down.
last
now.
note they have is he's in the hospital. Oh, you don't know if he's alive or dead.
Don't, yeah. And then the second patient that we showed here, I think several people had raised their hand. We actually elected not to do a decompressive hemicraniectomy here, and which was consistent with the trial data. He did progress to brain death about 5 days later, underwent organ donation. And then the last case, this was the very late presentation, patient who presented with a blown pupil and extreme lethargy. He did undergo the procedure. He had his bone flap put back on appropriately postoperatively, and he's now able to follow simple commands. He's not verbal, and he was transferred to a rehab facility when he left. He did, of note, we talked about the complications of surgery. This is not benign. This is an important discussion to have with the family. He did have an epidural hematoma that presented about 2 weeks post-op of getting his bone plate put back in. That was taken out, and he eventually had his bone flap put back in.
So we looked at some of our KU data here over the last 4 years. I mean, this data is only for patients who have received a decompressive craniectomy. So I don't have control arm for medical therapy, but you can imagine based on the trial data what that would look like. So we have 15 patients who underwent decompressive craniectomy, median age about 41 years, range from 60 to 79. 73% of them were females. Interestingly, 60% of them had a left-sided decompressive craniectomy, which is kind of goes against some of the trial data. Median admission NIH stroke scale of 19, median time to decompressive craniectomy of 24 hours. So 87% of these patients got a craniectomy within 48 hours. So if you were to cut down, stratify them by time, of the patients who got the craniectomy the earliest, majority of them went to rehab. 67% within 24 hours, 50% less than 48 hours. We don't have many numbers beyond 72 hours and 108 hours. I think the last one was the one that you guys saw at 7 days. Out of the 6 deaths out of 15, so palliative care, extubations, and deaths resulted in 4 patients, and 2 of patients, despite aggressive surgical medical management, progressed to brain death. So how do we get around constructing a clinical pathway? I think so. There are a lot of variables there. Sorry.
You don't have modified Rankin scores or anything like that?
Not yet. On our patients, yes. So how do we go on constructing a clinical pathway? Because I think there are 3 key players in the mix here: neurosurgery, stroke neurology, and neurocritical care. So I think it's important that all of us have a buy-in into, kind of a similar clinical pathway to offer the patient and the families the best that so everybody's coming to KU with the best intention. They get the best medical care, they get the best surgical care. So review of literature was very important for us. We also looked at some of the other clinical pathways that are out there, and we'll share them with you in a minute here. One is the Mass General Hospital clinical pathway, which has been there for quite a while now. And so we conducted a task force of neurosurgery, neurocritical care, and stroke neurology. And then I think we are in the phase of disseminating information and kind of creating our own database now. Because I think this will take many years of data for our institution as data evolves in clinical trials to see kind of where this all will end up with. So I think the 4 key players in this, Dr. Ebersol, Dr. Shah, myself, and Dr. Wang. And so the question is, how do we predict who's going to deteriorate? I think that was a question that was very difficult for us to answer. So how do we go about that? So if you look at some of the pathways that are out there, which are patients who are high risk group, including age appropriate or gaze deviation, NIH stroke scale of 15 or 20 in the dominant hemisphere, and any other imaging findings like clinical of nausea, vomiting, early CT scan with a large stroke, CT angiography with a proximal occlusion, and a DWI infarct volume greater than 145. I think so. That's one of the pathways. The other pathway here is the MGH pathway, and I really like this one because it has put a lot of thought into and stratified patients into who potentially might benefit from a craniectomy and who would not. So they propose what's called a STATE criteria. STATE stands for S for score, which is NIH or GCS. T is time, A is age, T is territory. So looking at the volume, the DWI volume, and E is expectation. I think that becomes a very controversial topic there as to life expectancy that is reasonable. Again, their setup is different and who makes those decisions. And so these are if the patient meets these criteria, then either at 24 hours is when they stratify them, of which patients are offered a decompressive craniectomy and which patients are not. Or if they have an asymmetrical pupil that we saw in one of our patients or a midline shift, then these are criteria for emergent hemicraniectomy. So based on their pathway, they divide patients into 3 categories: most likely to benefit, uncertain, and unlikely. I think this, again, data based on the trial is cut off at 75 years of age. I think above 75 years of age, it's proposed that these patients would be unlikely to benefit from a hemicraniectomy. And then they would undergo, medical management and then palliative consultation and things like that. So let's talk about constructing our own clinical pathway here and how we went about. And so I think Kush will talk about that a little bit.
So based on all the data that we've already reviewed, as well as other organizations' pathway that they have, we came up with our own. And I just want to start with a few intro points, which I think are the true key points. This really needs to be a multidisciplinary approach. We all take care of these patients together. We all speak with families, and we all work together on this. And so really an open door of communication between all three teams involved, and everyone involved is going to be really an important key point here. And that involves stroke neurology, the neurocritical care team, and neurosurgery. So I think it's very important that prior to giving recommendations to the patient and their family, that all three teams get together in a private setting and discuss, well, what do we think here? What are the pros and cons of offering or not offering the patient surgery? A lot of times it's confusing to family members when one team says you need to have this done, one team says you shouldn't have this done, and it already makes a tense situation even more difficult for those family members. The other point is that if the family chooses aggressive therapy, they need to be counseled that this is going to be a long road ahead for recovery, and that they should not expect results in a matter of days, weeks, or even months. You're probably looking at about 1 year out, and this is likely going to require tracheostomy, a peg tube placement, and rehab, and significant morbidity that will have to be worked on. If the hemicraniectomy is performed, it should be performed early in the appropriate situations. Performing it extremely late has not been shown to be of benefit in the clinical trial. And maximal medical management should be ongoing prior to and after surgical intervention. So the keys really are talking to the family, setting the expectations appropriately, which was the E in the state criteria, and making sure that we have open communication. So I'm just going to review our clinical pathway here that we've constructed, and this is going to be a lot of review based on the other clinical trials that we've put together. And so our patients should have an NIH stroke scale of greater than or equal to 16, and at least 1 point should be accounted for level of consciousness. CT scan should show at least 50% involvement of the MCA territory and or ACA territory involvement. The MRI scan should have greater than 145 centimeters cubed, and this is based on the other criteria. Now, this isn't absolutely necessary. Patients who either can't have an MRI due to device reasons, or patients who are not stable enough to have an MRI, this certainly would not exclude them from being a person offered the surgery. Their imaging should show some evidence of midline shift. Now, this is a little bit difficult because what do you do with the patient who's got some midline shift but is brightly awake, sitting there, and is not having any level of consciousness issues? On those patients, we recommend very close monitoring and CT scans for comparison that are done serially. And lastly, patients who agree to have the aggressive treatment should be also willing to have a tracheostomy, peg tube placement, and long-term care needs addressed, looking at long-term outcomes. So we also used the risk stratification that the straight criteria used. We used their data as a template and applied it to our own review of the literature. And we said that patients who are 18 to 60 in overall good health, who don't have any significant premorbid conditions, who don't have any contraindications to surgery, who are less than 48 hours from their stroke and have a greater than 3-year life expectancy, these patients are most likely to benefit decompressive hemicraniectomy. And we really feel that we should offer these patients this and give them an opportunity to have the best medical and surgical treatment available. Now, Dr. Lele nicely showed us some of the areas that are not quite clear. And so these are the uncertain to benefit from decompressive hemicraniectomy group. And these are patients who are 61 to 70 in good health, patients who are 18 to 60 in fair health, people who have multi-territory infarction involvement, and patients who have gotten thrombolytics and failed to improve despite that, and people who develop edema later than you would expect after 72 hours. So these are uncertain. We're not saying don't offer them, and we're not saying definitely offer them. I think these cases need to really be addressed on a case-by-case basis to see what the family's wishes are and what we believe would be the best outcomes for these patients. And then lastly, the unlikely to benefit are older patients greater than 70, people who are 61 to 70 but do not have overall good health. And people who, any age group that have life expectancy less than 3 years and poor overall health, people who are coagulopathic at the time, and I want to clarify that. That's not people who are on anticoagulation at all, but people who are coagulopathic at the time that they need surgery. These people would not, the risk at that point is quite grave. People who are poor surgical candidates, people who have contralateral infarct or hemorrhages, people who have evidence of significant intracranial hemorrhage either into the stroke or elsewhere, people who have a MRS scale higher than 1 even pre-stroke, people who have an entire hemispheric stroke that involves all 3 territories, who have received thrombolytics within the last 24 hours at the time of needing surgery, people with significant anoxia, drugs, poisonings that are related, and people who have actively herniated who already have bilateral fixed and dilated pupils. So someone asked earlier about the first case, would you offer that patient surgery? And based on this clinical pathway, he would fall into the unlikely to benefit, and for 2 reasons. Not only his age, but also he had complete ACA, MCA, and PCA territory infarction, and that would make him unlikely to benefit with the data that we have now. So this has led us to make a flow chart, which is pretty simple and straightforward. And so initially the patient's seen, usually stroke neurology is the first responders with the stroke alerts at the hospital, either in the ER or elsewhere, or on the phone from an outside facility, which is quite frequent. And these patients undergo an initial workup that what we would consider a standard stroke workup with either CT and or MRI if appropriate, have an initial stroke scale, have a GCS, and then we would evaluate them at that point right off the bat whether they would even be eligible for hemicraniectomy. If their volume criteria does not meet, then they should undergo medical management aggressively as deemed appropriate. If they do meet criteria, then we need to, at that point, risk stratify them into how their surgical eligibility will be. If they fall into the unlikely to benefit or have significant reasons not to because their DNR, DNI status or their wishes for a trach and peg are to never have that, then at that point they should be continued in the medical management. But if they do fit all those criteria and the family wants aggressive treatment and are willing to undergo all the steps necessary, at that point it is appropriate to have neurosurgery involved. The consult should be placed. A discussion should be had with all the teams. And this should be done, again, to stress this, prior to the family being told different things by different teams. And then together as a unit, the family should be told of thoughts of the group as well as what is or is not being offered at that time. And then lastly, it's broken up into dominant and non-dominant side. And this is a difficult delineation here because it's not completely known, and the MRS scales don't take dominant and non-dominant side strokes into account. So our feeling when we all got together was it should not be an exclusion criteria for the family by any means, but patients who have a dominant side stroke, there needs to be an additional discussion with them that their recovery may not go quite as well as someone with a non-dominant stroke. And even if what we would consider a good outcome after a surgical and medical treatment, they may still have permanent aphasia that may limit their improvement and may affect the family's decision. So, just conclude over. And the last thing I just wanted to say was, Dr. Lele showed that our data, what we've shown, this was retrospective, we were just looking, but our goals are to say, well, now we've got this data, we've got this clinical pathway, it would be of much more value to prospectively follow these patients out for years to come and show, well, how are our patients doing compared to the data that's available? Is it better? Is it the same? Is it worse? And that will help us go further in terms of what we should do.
So I think based on what you've heard so far, I think good summarized saying that decompressive hemicraniectomy does reduce short and long-term mortality, again in appropriately selected patients. Survivors do face significant disability but have a potential, for a MRS 3 or 4 or certainly a 2 but the efficacy of decompressive craniotomy in the elderly greater than 60 remains uncertain, although recent trial data has been very promising. So I think we can wait for some more trial data to kind of really tell us what these age group patients really end up doing. And then further trials to concentrate on multimodal approach to quality of life. It's not just MRS. I think there's much more to the story than that. And I think just to kind of wrap up, I think I've seen the pathway kind of evolve over many years, and I think one of the last patients to actually getting into the pathway was just not too long ago. This was just like last week. Age appropriate, time appropriate, surgically appropriate candidate. Again, offered craniectomy. We had a multidisciplinary team meeting with the family. Interestingly, just kind of put a thought out there, the patient was refusing surgery, but the family wanted surgery. And it came down to a neutral consultation with palliative care to really sit down with the patient so that to understand whether he's able to understand the implications of having surgery or not having surgery. Anyway, he proceeded with the surgery, and he's still requiring, despite a very generous craniectomy, very, very aggressive medical management beyond just intubation and sedation. So I think this topic will continue to evolve, I think, as we get more trial data. We looked at all major publications in neurosurgery, neurocritical care, and stroke neurology, and with the American Stroke Association. And so we thank you guys all for coming and listening to us, and we'll be happy to answer any questions.
Discussion you have with the family, you talk about what happens to the part of bone that's removed.
Yes.
And how do you preserve it? Some people put it under the skin, others will freeze it. I mean, how do you preserve it?
So that's a very good question. We talk about all that with the family, and you know, in terms of the question of where to put it, I think that's a decision that can be made by the practitioner with the family, depending on the case. We do have the ability to send the bone to a freezer that can be retrieved at a later date. And we also have the ability to put it in the subcutaneous tissue. I think from my standpoint, you know, if it's a young patient, you know, you have a 16, 18-year-old girl that would have a linear scar on the abdomen, which may be something that would be important, I think at that point it's very appropriate to say, you know, I think it'd be more, it would be recommended to send it to the freezer. Some patients would say, well, you know, I don't care about that, just, you know, put it in the belly, I don't mind. So to me, it doesn't make a big difference where it's put, but it is an important discussion to have the family with.
So there are several possibilities, as Kushal mentioned, and there are advantages and disadvantages to each. The hospital can store it in the freezer. I've had them get lost in the freezer before, so you put it there, and 2 months later you go back, where's the bone, and they've lost it. There is a service now that will take the bone, clean it, sterilize it, store it. It's quite expensive. It's done off-site, and you have to give them a few weeks' notice, but it's a very appropriate way of preserving the bone. And by far and away the cheapest, but at least cosmetically maybe a little deleterious, is putting it in the patient. At least you know where it is. It's sterile. It's kept with, there's an ingrowth of vessels that actually keeps the bone somewhat healthy, and when you put it back, I think it incorporates better. So it's individualized. Each one of us does it their own way.
Along those lines, I recently read about using the 3D printers to print part of the cranium. Have you guys looked into that much, or?
So you can, you know, that's something, you know, I'm personally interested in, but we've used, you know, you can get a prosthesis made. There's plenty of companies that can make prostheses, but in this situation, we're saving the bone. In a situation that it got infected, lost, you were unable to use their own bone, whether it was put in the belly or the freezer, I think that would be something that could be considered.
So that's actually how they make the prostheses with 3D printers. They've been doing this for a couple of years. You send it away. It's quite expensive as well. I mean, we're putting one in today. I think it costs $3,000 or $4,000 to make a little piece of bone this big.
You do duroplasty in all these cases?
I have in all the cases I've been involved.
What I mean by that is you cut the dura and you put it in the graft. You expand the...
Yeah, you fillet the dura. I mean, you want as wide
Right.
an opening as possible. So I'll make multiple slits, and basically you just allow the brain to fungate out. and then you just lay the dura back on and put some dural substitute on, and there's sort of a neo-dural membrane that forms. I just replaced the bone flap in one of these yesterday and didn't even see the cerebral cortex, even though we hadn't closed the dura at all, not even a stitch. It was just laid all these multiple flaps of dura on there, and then the covering of the artificial dura.
Yeah. So this is a great presentation. I'm really glad that we kind of talked about the different options, but I feel like the underlying theme of it is how do we prevent harm, and the harm in some cases would be maybe this word wasn't used, but the futility of providing a harmful procedure for people who won't benefit from it. Has there been, so two questions about that, and the first is, have there been studies, basically maybe informal surveys of families, whomever, at 3 years out, saying, knowing what you know now, would you go proceed with the procedure then? Has that question been asked with people who've gone through this?
I think very important question to answer. I think yes, there have been surveys out there that have been sent to families, and I know from personal experience as well with talking to Dr. Wang that I think the patients and the families, or rather the families who opted for surgical management, do not wish to take back their decision, I believe. So
basically, I ask, especially I think the 57-year-old. I mean, that case is kind of a delayed. Different stuff, but I did, talk with the wife. I asked her that's about 6 months out. I asked her if it happened to him again today, will you do the same? Will you make the same decision? She said yes. Yeah. So we actually not only we have a few other, our stroke coordinator. Back of the phone call, follow-up call. That is a key question we ask. Will you make the same decision? 3 months or 6 months, make the same decision. And most patients, I have not heard say no. I do not want to make the same decision.
But there have been studies where you ask the patient whether they would do this or not. Correct?
yes,
And it is a positive response or not?
I think for
understand
most
that it
part
is.
it's a positive response.
Right.
And I mean, I don't have the exact numbers to show here for those surveys, but I think predominantly of those, like you said, with the trial, the majority of them are right hemispherical craniectomies. So you would imagine that I think the patient will be able to make that, answer that survey later on. But I think overall, we haven't heard from from families or patients that they would not want to go with the procedure to give them a possibility of a good outcome. So.
Right. Well, I think it would be very hard for a family to sort of back down and say, no, it was a bad decision. That's the patient themselves. That's the rub there. They want it done or not.
Right. I think that's a good question, and I think some of the challenges with that is time. I think we don't have, when you're left with a large hemispherical infarct and we're dealing with aggressive medical care and getting the families together to discuss about all of this, it's almost comes to the point is, do you want it done or you don't want it done right now? And I think the question is, I do it right now, it's going to save somebody's life. They are kind of more in tune with that rather than focusing on the 3-6-1-3-year kind of the timeline. And I think that's something that maybe as the pathway evolves, one thought that I had, and I think we echoed that last week, is to get palliative care team involved in the decision-making process early on, because this is not something that you have to go into the OR within the next few minutes. I think we have a time to sit down and talk to the family and really understand the goals of care here, in not just DNI, DNR, but everything else. So I think that would help tremendously kind of get the patient's decision-making capacity into the mix. So. Yes.
Just a couple of comments. Number one, I am always surprised. We've done 15, 16 the last few years of the people with total MCA infarcts on the left who are able to talk or understand. Previously we've said, well, we're not going to do it on the left side because they're going to be completely aphasic. Well, we've got a number of young people, mostly, but even some older folks that are able to understand completely everything and say a few words to people that are talking, relatively well with an entire left ICA or MCA infarction. I remember a 21-year-old we did a few years ago. So I don't necessarily use that as much as a defining factor anymore on whether to do them. The second comment would be, are there any financial, healthcare provider considerations here? And to that end, how many of these studies were done in Canada or the UK, or systems where the health resources are finite. I mean, I know in the UK, you have a glioblastoma and you're 65 years old, you don't even get a biopsy in many cases. And so I'm not, where were a lot of the studies done? They're all European? Yeah.
Oh, Dr. Cameron already talked about it.
So when they've done quality of life analysis models, they'll rate your quality of life. 1 is normal life, 0 is death. We go down to -1. So people would rate like locked in, -1. Or hemiplegic, unable to walk and will talk, -1. So before the event happens, many people would rate the kind of survival as negative. And basically giving the preference that they would rather be dead than to be that way. And I agree with the other comment that after someone's made the decision to do it, it takes a lot of introspection to turn around and say, I made the wrong decision. 3 years out, my mother-in-law, large stroke, aphasic, has made it clear she wishes that she hadn't been saved. She didn't have hemicraniectomy, but she wishes that she'd been allowed to die. One of the other problems with the studies you're showing is you indicated a 3 MRS of 3 is kind of a reasonably good MRS. In order to show the benefit, many of those studies had to kind of compromise and say, well, if we allow the 4s and less, then there is this benefit. And that kind of is the question I think partly Dr. Lewinsky is asking here. Because then it comes down to fully being care dependent, and is this really the quality of life that people would desire? More to be discovered.
I think that'd be a great thing to do with our series.
You're doing the same analysis for post-traumatic problems as well, I'm assuming? No.
So we're patients.
I mean, decompressive craniectomy.
TBI, yeah. We're not. I think that's an excellent point, but I think that's just as valuable data. Obviously, the criteria is a little bit different. And the acuity of how these patients present is different. But I think that would be very valuable information.
Yeah, probably has been looked at. Before you talked, I ran a Medline insertion. There's 2.5 publications of this for stroke, but nothing for trauma, using national data sets.
I'm just going to get your great presentation to both of you. The key questions you actually asked at the beginning. The well person who has a malignant, a whole hemisphere stroke, who is still well in front of you. Theoretically, is the person most likely to benefit from decompression. I've faced that scenario, and what did you do? And the other side is the 85-year-old with comorbidities whose family wants to do everything in the book. Have you had to deal with those two extreme situations?
To answer the first question first, I think the question about a good neurological exam, but clearly a patient that is going to deteriorate. I think our thought process has been to go in and decompress. So not wait for them to have pupillary change or show significant midline shift. Just based on, so like for example, this last patient we did was 57 years old. Surgery was done even on TPA. This patient had gotten TPA and we did surgery within probably 6 hours or 8 hours after IV TPA.
8 hours.
No clinical change indicating herniation at that time. But still, I mean, we're only about 6 days out of it. But clearly, I mean, the edema is still probably peeking out right now. To answer the second question, I think based on our clinical pathway, the recommendation from our experts would be no to the family. And that's why I think we made it very clear that we want to regroup ourselves first before we approach it to the family. That 85-year-old patient, right now there is no data indicating that the outcome is going to be any better with decompressive craniectomy. So we would not be offering surgical management to that patient. That be fair to say, Kush?
Basically, open the question, back to the patient, is just to there is this procedure, this procedure will not save your lifespan a lot,
Thank you very
Thank
much.
you very much.
Thank you.